last speaker and I are pretty much the same height. Pretty much. I wanted to thank the organizers for actually having me for the second year in a row. I'm very grateful to be here and honored. I wanted to start off by actually talking about, this is a really cool subject because in fact there's really almost no data to talk about. And part of this is about semantics, part of this is about fear. There's been an overwhelming theme in this, how did I get to 6:30 already? I got hurt here. There's been an overwhelming majority of a theme about when it is that we should actually implant things. So the bottom line is that in fact PGD, or primary graft dysfunction, isn't really PGD. It's really EGS. It's early graft shock. Okay. I have no disclosures regarding this, but early graft dysfunction is really the ability for the heart to not do well in a setting where, in fact, otherwise should immediately within the 24-hour period. So people were talking earlier in this session regarding, when is the time to pull a trigger. If you're in the operating room, you can actually see a dilatation of a right atrium that's overly stressed for whatever reason within sometimes less than 10 or 20 minutes. You certainly can see a prolonged surgery that for no other reason other than the length of the surgery that in the course of an hour. So usually the initial intervention by the multidisciplinary team is -1 to 1 hour after. Then we repeat that about 4 hours, and then again at about 8 hours, so at 12 hours. And then we let them marinate overnight, typically under the supervision of an attending critical care intensivist, and the ability to have a surgeon or a heart failure doctor come in at any time. So really, primary graft dysfunction really is broken down, and the nomenclature is that these are patients that actually have ischemic reperfusion injuries, and they have suboptimal donor efforts. And what I mean by suboptimal donor efforts is that, in fact, we're taking so many more hearts because there are so few that, in fact, things have changed. And as a segue from the last speaker who was just saying how he can get somebody transplanted now in a couple of weeks, well, they may not be dying on the list, but it remains to be seen if they're going to be dying after the transplant now. The second part, or secondary secondary early graft dysfunction, is related to hyperacute rejection, or related to the ability for us to have to anticipate things that may go wrong in the operating room. And I usually put that on myself, our cardiologists, as well as our critical care doctors and anesthesiologists, to make sure that, in fact, we set the surgeons up for success. So this was a set of criteria. It's not very, very easy to see, but it basically breaks down primary graft dysfunction into two groups, left side and right side. And left side is broken down into minor, which is done by hemodynamics and the ability to need a low-dose inotrope. Moderate, which is the ability to have a cardiac index which is attenuated, elevated filling pressures, defined as a CVP of greater than 15, and the wedge is really not very robust. They're 20, which it's pretty low, and the need to have high-dose inotropes. And severe are those patients that actually are failing high-dose inotrope therapy that requires some type of mechanical intervention. Whereas the RV side talks about the ability to, when they're talking about primary graft dysfunction, they're looking at those patients that are not ones that you have missed because, in fact, you underestimated your transponder gradient. They have TPGs that are less than 15, and for our pediatricians, we typically look more at TPG than PVR, because TPG divided by cardiac output is PVR, and I can start you on epinephrine and make almost anybody's cardiac output less and your denominator significantly better. And then the last part is that, in fact, whether you actually need an RVAD or not. Barriers to understanding PGD report are related to the fact that they come from single centers, that in fact there's a lack of consensus guidelines until recently. In fact, there are no significant databases, and there's a general reluctance to actually talk about this, as everybody's program will close if in fact you can't fix it by yourself. So outcomes in 47 international programs, the incidence of PGD was 7.4%. that mortality among these patients was 30% at 30 days and 35% at 1 year. So if you made it past a month, you only had a 5% chance of dying. And the most common cause of 30-day mortality was related to multisystem organ failure or related to graft failure. Advances in organ preservation related to like PROCEED-2, and whether you're talking about cold preservation versus warm perfusion, have had some significant advancement. But however, what we are seeing is in fact that this is largely related to ischemic times that have increased, or for whatever reason, which I don't have an answer for, less than 30 minutes of ischemic time also leads to PGD. And that a contraction band necrosis is actually seen for the entire lifetime of the graft after that. So transplant programs have begun to consider and accept hearts that are suboptimal because, in fact, there are less out there. Patients over the age of 55, there's even some data from ISLT from last year suggesting a significant increase in mortality above the age of 42. Severe LV hypertrophy, non-obstructive coronary disease, all of these are now on the table, and additionally, some of these hearts now have been on significant amounts of intravenous vasopressors for a longer period of time as they do the brain death exam. Diabetes has become an issue because it's related to perfusion, that if you have microvascular disease, you are not going to perfuse the last portion of tissue of your heart. And from the ISLT database, we know that the utilization of amiodarone before surgery actually makes a significant difference in outcomes by increasing adverse events. Secondary to graft dysfunction, it results from a recipient's and many procedural factors. These include, among others, hyperacute rejection, a bad one, excessive volume of pressure overload in the OR, unrecognized pulmonary hypertension, and extensive intraoperative bleeding that can result in massive blood products and RV dysfunction. The most ominous cause is related to perioperative hyperacute rejection related to a allograft-mediated event. This historically was related to ABO mismatches, but with all of the things we actually have in place now, I don't think this really happens very commonly. I do think that one of the things that's made a significant difference is that we have elevated PRAs in almost all of our VAD patients now, and almost 50 to 60% of all of our transplant patients have VADs. And we don't know what those PRAs actually mean in those VAD patients, because for some of them, they go down very promptly after, whereas some of them, they stick around for a significant period of time. So in cardiac transplant practicing, has things changed? Yes. Donor issues have changed. Preservation strategies have changed. We can't even get our surgeons to actually agree on a preservation strategy within our own institution. And recipient issues have changed as well. Where amiodarone, also one of the proposed mechanisms, is actually related to the ability to decrease perfusion at the time of surgery. Medical treatments include high-dose inotropes, as we all know, prostaglandins, which everybody talked about, the ability to actually initiate therapy very quickly, and as we all know, it's insulting in this group to talk about steroids and ATG and those things. Surgical strategies to reduce PGD, I borrowed this from Carmelo Milano, was to perform anastomosis, some after perfusion, cardioplegia during the implant, cooling strategy during implant, vent the LV if required at rewarming to stop distension of the ventricle, leukocyte filtration on cardiopulmonary bypass, inhaled NO, perioperative cyclosporin, and the reason that makes a difference is using any calcineurin inhibitor from a molecular standpoint attenuates post-surgical ischemia. This shows surgical therapies. I have one more slide after this. And it shows using an intra-aortic balloon pump, which gives you a total of 500 mLs of blood max. Not a big fan. RVAD support, percutaneous RVADs, the ability to use a temporary BiVAD system versus ECMO. When to retransplant? So I told you if you made it to 30 days, you actually had a 30% mortality at 30 days, but only 35 at a year. And we know that those that get early retransplantation don't do very well. As a consequence, we've made a recommendation that, in fact, that you got to kind of hang in there, and if you can get to 30 days, those are patients that do well with retransplantation. Thank you very much.
David, great talk as always. One of the things that comes up, as you allude to on your later slides, was what device for which patient. And in my mind, the concept has been, go big or go home in that if you have overt graft dysfunction with hypotension and acid base, support the heart, don't flog the heart or the body with pressors, inotropes, and then reassess with the likelihood that secondary causes are not the issue. But I'm interested in your thoughts related to ECMO versus the other types of devices.
Jerry, I totally agree. Whether you're successful or not is that you're not going to do very well if your doctor doesn't know why you're dying. So the etiologic basis for why it is that you're not doing well, I think, is particularly relevant. I also agree with what Ali said in the last talk about the fact that we use pressors, but pressors kill people. And I don't think that you can actually determine how far you actually get. So I'm not a big fan of Impella because, I think that Impella, even, the larger ones, are hemolysis machines, and so after about 3 to 4 days, they're not particularly terrific. If I think that, in fact, it's very short term, I think that that's not at all unreasonable. If this was related to perhaps preservation, they get better in 3 to 4 days. The data suggests that for most of these with primary graft dysfunction, and there are a lot of programs that are very big, that are very good with a lot of very smart people that are having problems with PGD. And so I agree with you that, what it shows me is a lot we don't know. And so I want the buffer of actually knowing that I not only have full support, but I have an adequate amount of time on my hands. So we can support somebody on an ECMO circuit for 6 weeks easily. And the cannulas we use is, my fellows texted me about this. We typically use, we do an angiogram to make a determination. We always do distal cannulation. And then we put in, the smallest we ever put in arterially is 17, usually closer to 21. And we put in between a 25 to a 29 venous sheath. After dilatation, of course.
I agree with that approach, except if you have biventricular failure. That's the only case which we're going for Centrimac BiVAD. But if it's a right heart, predominantly right heart problem, I think ECMO is going to help you close the chest, prevent bleeding, reverse heparin. It's a good approach, and for 6 weeks you can manage the patient on ECMO to give him a chance for the heart to recover and not to go high with inotropes.
I don't want to oversimplify it, but one of the things that we look at, for that right-sided heart failure, because, you could look at Rob Mitchell's work from, probably 20 years ago now, Columbia, where he showed that in the first month, after, we weren't dealing with acute rejection anymore, patients died because of right-sided heart failure. So as a consequence of that, I was going to say, I don't want to oversimplify it, but, we follow the CVPs very carefully. Because I use this as an indicator of how well they're doing. The other thing we actually do as well, which is a non-mechanical, non-pharmacologic therapy, is that we'll pace them at 110. Because if you're emptying your ventricle, okay, these are new hearts, so they're very pliable, and you empty a right ventricle 110 times a minute, stroke volume times heart rate equals cardiac output, and I have unloaded that ventricle 110 times a minute.
I agree 100% on the heart rate. 110 even.
I have a question regarding, so great talk, first of all. We discussed before the patients that are on ECMO, and I think they to some extent represent a significant problem when they get transplanted from ECMO, especially with that fraction of the patients that start having lung problems because the PVR goes up and the risk of RV failure obviously post-transplant. Do you have any particular strategies for patients that are on ECMO that you plan to transplant from ECMO with respect to early decompression or other strategies, or how do you follow the pulmonary vascular resistance in those patients that you anticipate to transplant from ECMO?
Yeah, that's a really good question and a hard one, Finn. And at least in the United States, things have actually started to change with the reallocation system. We have very good results with ECMO, but I don't think that by definition, the idea of, those status 1 patients in the United States being ECMO patients, that them going directly to transplant, I'm not certain these outcomes are actually going to bear out. Certainly the federal government's going to hold us accountable for still having a 90% success rate, and I've never heard of a program closing that I'm aware of because of patients dying on the list. So in the old days, before we changed the allocation system in the United States, we would stabilize them, get them buffed, make a decision whether we could get away with a durable LVAD, and if not, we would put in BiVADs. We have TAH, but we don't use it because we feel equally comfortable and can get patients walking and extubated with BiVADs. Now in the modern era, I'm not really sure what the answer is.
At our center, we had a patient who had hypertrophic cardiomyopathy. waited on ECMO for 30 days. So we had the pediatric interventionalist do a septostomy because they had a better balloon to create a 1 centimeter ASD, and we supported the patient for 30 days, and she got transplanted. That was before the new allocation system came about.
And certainly, there's no way out from that. Doing septostomies, Ali can comment on this, that this was a very common strategy in Germany and in Switzerland for a period of time. The results were mixed.
It's a very good question, and I think we have to think about that to see criteria for even taking patient from long-term ECMO to an LVAD or heart transplant. And what we're doing, and we are reporting our data here, is going to be presented in an International Society for Heart-Lung Transplant meeting on transitioning patient from ECMO to LVAD. And we're following the same criteria. The patient should be extubated. All organs functional, like in any other patient going for LVAD, except the kidney, the only organ we are doing exception on that. The patient is talking to us. That means he is not congested. If he is extubated, that's the lung is okay. And to look to the pulmonary vascular system, we're reducing the ECMO flow and watching the pulmonary artery pressure to see how that's going to go. We don't have better way to look for that. But it's our strict criteria, like we're doing for the LVAD, that we're trying to follow that with the ECMO. And we have 2 cases after the change allocation. Both of them are successfully transplanted without problems.
So, question, you do an 18-year-old donor tomorrow, the heart comes out and doesn't work worth a darn. Do you do central ECMO? Do you do peripheral ECMO? Do you have your surgeon put peripheral ECMO with a graft? Because this will happen. Perfect heart, no immunologic problem, and the heart just doesn't work. And
Both sides of the heart doesn't work. Or one side.
Both sides, just doesn't.
In such kind of case, we're doing CenturyMac BiVAD. That's why I'm biventricular CenturyMac BiVAD.
So you would do CenturyMag BiVAD as opposed to just put on ECMO of some sort? I don't know the answer.
He's asking about post-heart transplant.
Post-heart transplant.
Yeah, post-heart transplant.
Yeah.
Yeah, no, so,
Both sides.
yeah.
I think it's controversial, which is why I asked.
Yeah.
Yeah.
1 second.
You just did the transplant, the heart.
So you're in the OR, right, David?
Yes.
Okay.
It doesn't work. Chest is open.
All right, so when you have a stone heart, it just doesn't start. You can't expect that heart to act. That's 18 years old. Best case scenario is this is a perfusion issue. Worst case scenario is you have primary graft failure and you're looking at one of the 3 or 4 times you may see that in your entire career. I would favor Ali's approach, which would be to do BiVADs. And I would favor, if it ain't starting in the OR, you do it before you leave. And that patient's going to have a very high mortality.
So I think it remains controversial in that even when it, stone versus not working well or appears to be very, very overtly stunned. We've seen cases where using central ECMO, aggressive strategies with venting, in time, in reassessment, you can get that heart working again with the likelihood that maybe there's ischemic reperfusion injury. And so I think we don't know, but to do bilateral CenturyMags on a fresh heart transplant is not without its sequelae. So I think we don't have data to guide us, but our bias at the Cleveland Clinic, which was the same at Houston Methodist, would be central ECMO.
Yeah, I've lived through both eras, in an era when we used to do BiVAD CenturyMags for this, but have been impressed with the last few cases I've seen over time. And people from Columbia have made the comment that central ECMO, and then the next day switch it over to peripheral and close the chest, wake them up. Having sort of lived long enough to make all the mistakes, if you keep the chest open on central ECMO, nothing good happens.
But how are you going to allow the left ventricle? If you have severe biventricular failure, ECMO is not going to allow that patient. And if we talk about severe, stone heart, is the left heart is not moving. That's the ECMO is not going to be the best approach, right? Except if the LV still have certain degree of contractility, which is different. But we saw this patient. Both sides of the hearts are stone.
The aortic valve has to open.
Sorry?
The aortic valve has to open.
But
Otherwise, you're in
yes,
trouble.
Yeah,
You can put us in the OR. They put a little small vent right in the apex of the LV, much smaller than a CenturyMag cannula. Right?
Question over here.
Eddie?
This is really interesting. We're looking at our data now. So we're looking at our data now. Years ago, Hansi Matelier, who was a fellow with us, looked at our ECMO post transplant ECMO data, VA ECMO only, and it was about 80% central VA ECMO, and then the rest was a delayed to VA ECMO peripherally placed in the CT SICU urgently. Ali, I think these stone hearts are not the same stone hearts as you see in a post-cardiotomy case. I think there's something, I don't know what it is, because they wake up earlier. So I think to Jerry's point, I mean, we want to study it. We probably can't retrospectively, but I think it's an important question is, what is the time frame of recovery on central VA ECMO post PGD or EGF? And I think it's sooner. So to Jerry's point, I think central VA ECMO is a great strategy. And what Mike does, Acker, is he leaves the, well, some of the patients are on a balloon pump. He leaves the balloon pump in. So it's central VA ECMO with a balloon pump, or he puts a balloon pump into, and we've had unbelievable success, thank God. Otherwise, we would be one of those transplant centers.
So,
If you are monitoring your LA on those patients, and LA is low, I would agree on that. If the LA is high, I would not agree with that because it's a central thing for the recovery.
so if this is primary graft dysfunction in that primary category that I mentioned, they're going to recover likely in 3 to 5 days. If this is because of allograft because of an allograft, epitope phenomena, you're looking at 2 weeks of that heart not moving.
But Dave, I mean, you and I both know that's rare.
Yeah, it's rare. Which gets to my point, which is that if your doctor doesn't actually know why you're dying, you're in trouble.
Just one last question. Do you think it's time to try to have a registry on this entity in which, you started by saying that there's not enough data, there are single center studies, and that we really don't know if it's primary or secondary at times?
The answer's got to be yes. More, when we don't have the right answer, more data always helps. So, yeah, right. All my cases that crapped out.
Okay, thank you very much. Because of time, we're going to